Welcome, everybody. We will get started here in just a minute. We're just waiting for everyone to filter in from the waiting room. Got quite a few people registered today, so we're expecting a good crowd. While we're waiting, I see that Kathleen from Signal has put our brand new report in the chat, so feel free to click on that link and check out the report that we'll be presenting today. We'll be walking you through it, finding by finding. All right, well, it looks like the filtering in has kind of stabilized, so we'll go ahead and get started. I am so happy to welcome you all today for the third briefing on our viral hepatitis surveillance status report. We at HepVu are here together with our friends at NASTAD to do the 2023 surveillance status report public briefing. And as I said, we are releasing the report as of today. The report can be accessed on our website, and we've got a link to the report right in the chat. And you're able to access all of the wonderful infographics and a lot of other resources on the website. So very excited to launch this report today. Thank you so much for being here, and we're really excited to tell you all about it. So I'll start with some quick introductions. I'm Heather Bradley. For those of you who have not attended a HepVu webinar before, I'm the project director at HepVu. HepVu is a Powered by AIDSView online program. AIDSView is our, we like to say our big sister site. And AIDSView and HepVu are online platforms that visualize data and disseminate insights. HepVu on the viral hepatitis epidemic, AIDSView on the HIV epidemic across the US. These platforms are presented by the Rollins School of Public Health at Emory in partnership with Gilead Sciences. And I am also an associate professor of epidemiology at Rollins. And I'm here with my friend, Dr. Isabel Lechuga at NASTAD, our partners in this project, and I will let her introduce herself.
Sure, absolutely. Thank you so much. Isabella Chuga. Most importantly, I use she, her pronouns. I am on the hepatitis team at NASTAD, and it has been just a pleasure, and I feel really honored to be included in the space amongst y'all. We have been big fans of AIDSView for many, many years, advocates and very loud supporters, and so the expansion to HepVu has been so wonderful. And the fact that we're here for the third year is just really a testament to y'all's dedication. And I also am very pleased with the attention to detail and all the accountability y'all make sure, especially considering all these volatile times. So really appreciate it. It's more like introducing myself, but showing my appreciation for y'all, really.
Same. This has just been a really wonderful partnership with NASTAD and a very fun team to be a part of. I also want to take a moment to appreciate Dr. Melissa Wardle, who has been part of our Emory team. Melissa has really been the main point of contact to the jurisdictions on this report. She fielded this year's survey, collected the data, analyzed the data, pulled together the main insights for this report, and helped us achieve a very high response rate at 97%, our highest response rate to date. So together with the jurisdictions, Melissa is really responsible for a very successful report this year. And so Melissa's going to help us to present some of the findings today. And we're just so happy that she's here and that she's been part of our team. I wish that we could go around and introduce ourselves on the call. We've got a big group today. So unfortunately, we won't have time for that, but we will have time for a Q&A and some discussion at the end. If you do have questions as we go along, please feel free to go ahead and type them in the Q&A box so you don't forget them. And we will be sure to get to those at the end, but you can put those in the Q&A box at any time throughout the call. All right. So now that we've done some introductions, we are going to move on to briefly discuss the purpose and goals of the surveillance status report. For those of you who haven't been to a surveillance status report briefing before, we'll kind of level set on, what we at HepVu and NASTAD sort of set out to accomplish with this report and how it sort of came about. Next, we'll present the approach and findings from this year's report. And then I'll spend a few minutes at the end talking about the future of the surveillance status report in the coming years. And then, as I mentioned, we will have some time at the end for question and answers and discussion. Okay, so let's talk a little bit about just the concept for the surveillance status report. So a little bit about how this work got started. A few years ago, we've been HepVu and NASTAD have had a great relationship for a long time, really since the beginning of the HepVu project. And together with NASTAD, we really saw this need to help jurisdictions and our advocacy partners to highlight growing surveillance programs in the US. We saw that, despite really limited funding for viral hepatitis surveillance in the US, the jurisdictions were doing really impressive work. And yet there was so much more that was needed in terms of resources and work. And so, we don't talk a whole lot about surveillance and the need for surveillance in the public eye. And so we saw a need to highlight, not only to highlight, what was being done, but to talk about what more needed to be done. And so we wanted to demonstrate the value of viral hepatitis surveillance and the need for more resources, particularly as this conversation has advanced around striving for elimination goals. And so the stated goals of the surveillance status report work are to assess how jurisdictions across the US are measuring the impact of viral hepatitis on their communities, to identify best practices, and to highlight areas in need of additional resources. And so the first report, which was released a few years ago, focused on jurisdictions' baseline surveillance activities during the first 6 months of 2021. And this was just before CDC funding expansion to all 59 jurisdictions that are being funded currently. And the dissemination for that report focused on about 15 indicators of surveillance capacity. The second report showed change over time in terms of those indicators and showed some progress towards strengthening and expanding capacity for viral hepatitis surveillance. But we knew from the beginning that the real insight here would come from future reports. And what's exciting is that the future is here. The future is today. The present report that we'll be showing you today has year-over-year updates. And so we now have 3 years of data. And this is where we get to monitor change over time. So we started with the baseline, and now we have 2 years of data, post CDC funding expansion, and we're really able to see, what kinds of impacts that funding has had and where resources are still needed. And so I think at this point, we are really realizing the goals of what we set out to do with the surveillance status report. And we're excited because we are seeing some growth. And we are seeing some areas, where more resources are still needed. And so we will continue to do this work every year because we feel like we've really been able to show what we set out to do here. So I do want to take a moment to thank a few people. You know, First and foremost, I really want to thank the jurisdictional representatives who responded to the survey. We would not have this report without our jurisdiction partners. The jurisdiction partners are not only the ones doing the work here, but they are also the ones who, nearly all 59 jurisdictions who are doing so much work with so few resources sat down and completed this survey. Not only, the questions that they could answer yes or no, or choose from a variety of options, but they also answered multiple open-ended questions in a lot of detail. And so we're just very generous with their time. But they're not just answering the survey, they're doing really hard work that goes way beyond answering the survey and into the real world, work that impacts people in marginalized groups who are living with viral hepatitis and have risk for viral hepatitis. And so this report really is for the jurisdictions to show how much work these jurisdictions are doing with so few resources and to show where we as a field can and should be supporting these jurisdictions even more. I also want to thank CDC for their informal support of this work. Particularly in the beginning of this survey, when we were thinking through indicators to ask about. CDC was very helpful in helping us think through what kinds of things would be instrumental to put on the survey, and in serving on our steering committee for the work. And then last, I want to thank Signal Group for we launched this report to the jurisdictions a week ago to give them a first look, and I said, surveillance isn't necessarily sexy, but we've got the prettiest report out there, and that bears repeating because our friends at Signal always produce just beautiful work, and I know you'll agree when you see this year's report. So thanks to everybody. Okay. So I want to talk just briefly about the concept of the report by answering three simple questions. So why now, and how did we create this report series? First, why did we see a need for the viral hepatitis surveillance status report? Well, many of you who are on this call right now know that the need for standardized and reliable viral hepatitis surveillance continues to impact and impede response strategies across the US. We still have a lack of robust surveillance data, and this limits our ability to monitor disease burden, including disparities. It limits our ability to track changes in the epidemic and to mount effective public health responses. And ultimately, it limits our ability to eliminate viral hepatitis in the US. So why now? Well, in 2021, CDC released new funding for viral hepatitis surveillance across 59 jurisdictions. Some of you may not know that prior to that, only 14 jurisdictions in the US were actually funded for viral hepatitis surveillance at the federal level. And so the first surveillance status report that we launched a few years ago was meant to allow policymakers and other stakeholders to really benchmark the current state of viral hepatitis surveillance in the US prior to this sort of launch of expanded funding. Annually, the point is to allow the field to monitor changes over time alongside changing allocation of resources. And we've again, this year is we finally have 3 years of data, And we're starting to really realize the goals and the aims of this report, which is that, monitoring change over time allows us to demonstrate continued needs for funding, staff, and other kinds of support, and really to better understand what kinds of resources are needed to build surveillance capacity in this area. So, so the short story of how we did this is that HepVu and NASTAD started by working with the steering committee. And this steering committee was comprised of state and local health department representatives, national policy and advocacy organizations, and a few researchers. So, as a group, we developed a set of indicators for assessing important surveillance practices in jurisdictions. And each year, we collect data from jurisdictions on these indicators, mostly the same indicators. We also ask the jurisdictions each year, are there other things you think we should be asking about? And every year there are things that the jurisdictions want us to ask them about. And so we do end up adding questions or changing tweaking a little bit each year. And so those results are analyzed year over year, and then we prepare the surveillance status report that you all see posted on the website describing findings over time. So the very first surveillance status report was released in 2022, and this inaugural report had four main goals. Again, this report was meant to benchmark the state of viral hepatitis surveillance activities prior to the new federal funding dissemination to all 59 jurisdictions, and really to establish a baseline against which we could monitor changes over time in surveillance capacity as additional resources were allocated. We really wanted to simply assess how jurisdictions across the US were measuring the impact of viral hepatitis on their communities at that time, and to highlight areas in need of additional resources. Next slide, please. So the second report was released the following year in 2023, and this was the first year that we were able to present year-over-year changes. So we had now a baseline year and one follow-up year of data. And in this report, we showed comparisons to baseline in areas including contact tracing, data matching, elimination plans and goals, data to address disparities in viral hepatitis burden, dedicated capacity for surveillance activities, and funding sources used for surveillance. Next slide. Now, for this year's report, we have three data points, which for those of you who are epidemiologists or epidemiology adjacent know that this starts to be suggestive of trends over time. And so in this 2023 report, you'll see comparisons over time for topics, including staffing capacity, case investigation and contact tracing, pregnancy status data. Again, we'll focus on health disparities data and case matching, and then, of course, elimination plans and dissemination of elimination plans. We do have a new section this year highlighting the importance of funding to ensure continued growth in surveillance capacity. We added this, in this year's report specifically to address, what we know are potential threats to funding for viral hepatitis surveillance. We are fortunate to have some data over the last 3 years showing that that funding for viral hepatitis surveillance is important and that it works. That jurisdictions have been able to do an awful lot in 3 short years with expanded funding for surveillance activities. And so I think, you'll see that there are some powerful data points in this year's report showing the importance of funding And we know that our advocacy partners will really be able to use these data points to argue for sustained and increased funding in this area. Next slide, please. Okay, let's get to the findings. Before we get on to the findings, I'm going to pass the mic to Melissa to talk for just a moment about data collection and analysis.
Thanks, Heather. Yeah, so just to recap our data collection process this year, or for this report rather, so data were collected between August and October of 2024. And we asked jurisdictions to report on the status of their surveillance system for the full 2023 calendar year. And as Heather mentioned previously, we had a really impressive response rate of 97%. And I'd also it was our highest ever. And I just would really like to shout out to those jurisdictions for working together with their teams and taking time out of their schedules to provide such rich data for us to summarize in this report. But once data were collected, or once data collection was complete, rather, we cleaned and then combined the data with previous years. And once data were finalized and summarized, we shared those with the steering committee to discuss and prioritize which results should be presented in this year's report. And so today we're going to be sharing highlights from the report, which include results from 2023 overall, as well as trends over time between 2021 and 2023. And we'll also include some results to look at differences by funding status. So jurisdictions that were funded prior to 2021 versus those that were newly funded. Next slide. Handing it back over to Heather.
Melissa. All right, so finally, getting into this year's report findings. So we dedicate some space in these reports to really setting the stage, right? Because we want these reports to be broadly accessible. It's really important to us that people outside the viral hepatitis surveillance world can understand and use these reports. And that's because we want our advocacy partners to be able to take these reports to the Hill and convince, folks who fund this kind of work that viral hepatitis surveillance is important, right? And convince people who really don't know a whole lot about what surveillance is, that viral hepatitis surveillance is important. And so we do spend quite a bit of space here setting the stage. And even though most of you, if probably all of you, don't need to be told any of these things, I just wanted to show you how we kind of set the table here. So as with other years, we open up the report by talking about viral hepatitis burden, as well as how funding for viral hepatitis has changed since 2021. The vast majority of people don't understand the inner workings of federal funding for viral hepatitis surveillance, and that's okay, right? We don't need them to unless we're asking them for money. And so we start out by talking in very layperson's terms about this expansion of funding in 2021 and the great burden of hepatitis B and hepatitis C. And we feel like, this is very important context. Next slide, please. The other piece of really important context for people who may be outside our field is, what is the purpose of surveillance, and how does the amount of funding that's spent on viral hepatitis surveillance compared to surveillance for other infectious diseases. And so in the report setup, again, as with other years, we lay out some basic burden of disease questions that rely on robust surveillance systems, right? We also briefly discussed the amount of funding at the federal level for viral hepatitis surveillance compared to HIV surveillance. I do want to note that this report presents findings from 2023. And so the amount that we cite as dedicated to HIV surveillance was also for 2023, recognizing that future amounts for HIV and viral hepatitis surveillance are unknown. This report, including the comparisons to HIV and the findings, all reflect the year 2023. But we do really want to put viral hepatitis surveillance in context. Why is it important? How much money do we spend on it? And how does this compare to other infectious diseases in terms of the burden, of disease and how, and um, how we devote resources as a country, to measuring that burden. Next slide, please. So we really open and close this year's report with a discussion about funding. And I've already sort of explained, why we thought it was super important this year to do that. And so here we're opening the report with a discussion about the kinds of surveillance practices that funding allows jurisdictions to do, and the importance of using a braided funding approach, and by that I mean an approach where both federal and non-federal resources are used to fund viral hepatitis surveillance. So in the figure here on the right, you can see that the percentage of jurisdictions that report using both federal and non-federal funds for viral hepatitis activities has increased a lot between 2022 and 2023. So on the left, you're looking at jurisdictions that reported using funding from another jurisdictional program for viral hepatitis surveillance, in addition to the CDC funding that's dedicated to surveillance activities. So increasing from 28% to 60% in just this 1 year period. And then on the right, we're seeing that jurisdictions reporting using state funding for viral hepatitis surveillance activities increased from 15% to 39% in just this 1 year period. So these are large increases in jurisdictions that are reporting using, other funding outside of federal sources, which is not a bad thing, right? This is do we wish that we had, enough federal funding to completely cover everything that we need for viral hepatitis surveillance? Of course. Should we be proud that jurisdictions are able to put together other sources of funding to cover surveillance activities? Absolutely, right? I think, this is sort of a mixed bag, but I do think that it's important to show that jurisdictions are putting together packages of funding from other sources to fund their surveillance activities and to give the jurisdictions credit for doing so. I also want to point out the quote on the left here about the use of a braided approach, and to say that when you look at this year's report, you'll see quotes throughout from the respondents. This is another difference from last year's report. We did have folks just being very generous with their time and answering open-ended questions, and we were able to use these quotes to contextualize some of the findings. And I think that this really added to the richness of the report and helped us to better understand some of the quantitative findings a bit better. So I think that you all will really enjoy reading some of these words directly from the respondents and not necessarily interpreted in our words. Okay, I'm going to pass to Melissa for the next few finding slides.
Thanks, Heather. Okay, so with staffing, we see that each year we've conducted the survey, there's been a growing proportion of jurisdictions reporting at least one full-time employee dedicated to viral hepatitis. So back in 2021, when we first conducted the survey, there were just 68% of jurisdictions reporting having one full-time employee. And now in 2023, it was up to 88%. But even with that progress, jurisdictions still reported needing more staff to effectively carry out all the different surveillance activities. So on average, across all jurisdictions, there was an average of one full-time employee, but they reported that they actually need about 4 to meet the demands of the work. And similar to the quotes that were provided on the previous slide, we have some quote here as well to contextualize this. So even beyond just kind of the numbers that we see here, jurisdictions provided really rich information about different staffing challenges that they experienced, including restrictive processes for getting people onboarded, insufficient compensation that aligns with like the skills that were needed for setting up and conducting a robust surveillance system for hepatitis, for viral hepatitis. There was also more common issues like high turnover, and then also like things like related to funding, such as funding uncertainty and making long-term planning related to their staffing and their surveillance systems without knowing like where funding might be coming from in future years. And so this altogether really highlighted the continued need for more workforce support. Next slide, please. So next, we have case investigation and contact tracing activities, which are really essential for identifying how hepatitis B and C spread, and also identifying who might be at risk and who might need to be screened or tested and provided with services as well. So between 2022 and 2023, more jurisdictions were able to carry out all these activities related to case investigation and contact tracing. We saw steady gains across the board. So more were reviewing prior case records, more were reviewing medical chart data, as well as more jurisdictions were able to follow up with patients to identify others who may have been exposed. So for both hepatitis B and C, we saw smaller increases for those who were reviewing past records, as well as medical records. But then we saw a pretty large jump up to 16 percentage points in those who were who are taking those new cases and using them to talk to patients to gather information for contacting patients. So these trends really point to progress in the local public health capacity to both track and respond to viral hepatitis cases that were being reported to the jurisdictions. Next slide, please. Okay, so additionally, we asked about jurisdictions that collect information on pregnancy status data related to viral hepatitis. And this is really important for prevention and treatment. It's a critical opportunity in that it provides this opportunity to ensure that people are screened during pregnancy and can support both timely treatment for the parent and the child after birth. And between 20 2021 and 2023, we did see mixed progress. So for hepatitis C, we saw that more jurisdictions made pregnancy status reportable with a 13% increase. But for hepatitis B, there was an 18% decrease. So this kind of raises flags about potential missed opportunities for prevention and care, at least with respect to hepatitis B. Actually for both, like, sorry, like they're both kind of like around approximately a half to 2/3 of jurisdictions are reporting. So even though we're seeing gains, like when we're really looking at these numbers, there's still a lot of opportunity for growth in this indicator. Next slide, please. Okay, so next with data dissemination. So publishing annual surveillance summaries such as case estimates for hepatitis B and C is really helpful for guiding public health planning and also targeting resources effectively. And in 2023, there was 65% of jurisdictions were able to produce these summaries. But on the other side of that, it just means that 35% were unable, which really does highlight another significant gap, an opportunity to grow uh, in regards to like support and needs and capacity. So yeah, sorry, next slide, please. And then finally, just kind of breaking these annual estimates down to hepatitis B and C. In 2023, we did see that over 80% of jurisdictions were able to report annual case estimates for both hepatitis B and C, but far fewer were able to produce prevalence estimates, with just 16% reporting prevalence estimates for hepatitis B and 25% producing prevalence estimates for hepatitis C. And this is important because while case estimates reflect the number of new or reported cases within the jurisdiction, prevalence really gives us a fuller picture of, the proportion of people who are currently living with the disease in the population and who are in need of support and services for their infection. Next slide, please. Okay, and I think I'm going to hand it back over to Heather.
Thanks, Melissa. One place that we were really heartened to see progress this year in the report is in terms of the jurisdiction's ability to collect and process data to address health disparities in viral hepatitis. So we asked jurisdictions about whether they feel they have adequate data to assess and address viral hepatitis disparities in a number of areas. And so we ask about, you can see here, race, ethnicity, urbanicity, risk factor, and that would include, for example, people who inject drugs, birthplace and sexual orientation and gender identity. And in most of these areas, we did see that there was an increase in the percentage of jurisdictions that said they felt they had adequate data to assess, to understand, and to act on disparities in these areas, particularly in the areas of race, ethnicity, and urbanicity, and a particularly high jump in the area of race ethnicity from 54% to 77% in just 1 year. So very heartening there. We did see smaller increases in terms of risk factor and birthplace disparities. And unfortunately, we saw a decline in one area, which was in the area of sexual orientation and gender identity. And this is really important to point out because this, suggests an area where there is a real need for more attention and improvement in coming years, because only 21% of jurisdictions, felt that they had enough data to really understand disparities in this area and to act on them. Next slide, please. Another area that we saw some really good progress was in the number of jurisdictions with viral hepatitis elimination plans. So the percentage of jurisdictions with viral hepatitis elimination plans increased from 43% in the baseline year of 2021 to 79% in this most recent year, 2023. So just over 2 years, 43% to 79%, a huge increase there with this expanded funding. 49% in 2023 have public elimination plans. So 79%, right, have plans. 49% have public plans, so there is a drop off, right? And 61% are implementing plans. So there are a number of jurisdictions that have plans who have not made them public and are not are not currently implementing them. So we do see areas for improvement in terms of implementation there, even though both of those percentages are improvements over past years. Certainly, we see that more resources are needed in terms of having capacity to really implement and to make progress on those elimination plans. In 2023, only 26% of jurisdictions said that they had capacity to make progress toward their elimination goals, and only 35% said that they had capacity to measure progress toward those goals. So again, there seems to be a real disconnect between having a written plan and the ability to make progress on that plan given resource constraints. And last, only 7% of jurisdictions said that they felt they could make progress toward their elimination goals at current levels of CDC funding for viral hepatitis surveillance. And so I think this is a really year over year, this is an important data point for us, suggesting that, in order to meet national goals for viral hepatitis surveillance, having plans is important, certainly, and it's very encouraging to see this growth in the number of jurisdictions with plans. But operationally, many more resources will be needed to be able to realize the goals that are outlined in those plans. Next slide, please. Okay, so just a couple of closing slides in this finding section on the new section of the report, where we really try to demonstrate the importance of funding for viral hepatitis surveillance. So we looked at a few important indicators over these 3 data points, and we stratified by jurisdictions who did and did not receive federal funding prior to 2021. So we're calling these jurisdictions prior funded and newly funded. And so the prior funded jurisdictions, or those 14 jurisdictions who were receiving funding prior to 2021, and those are illustrated by the orange line. And the newly funded jurisdictions are the jurisdictions who were included in this expanded funding in 2021 and later years, right? And they're illustrated here in the sort of teal line. So most of the jurisdictions in the survey then fall in this kind of teal line, right? Because a minority of them were receiving funding prior to 2021. And so what we really show in these 3 indicators that you're going to see here is that over just 2 years, the newly funded jurisdictions have made really rapid and sustained progress in their surveillance capacity. And they've shown at least equal progress to the progress that's been seen in the more established programs, with the expanded funding, they've been able to ramp up their surveillance capacity very quickly. The rate of change has been, again, at least equal to what we've seen in the more established programs, showing that these jurisdictions are capable of doing a lot with the funding that they're receiving, even though even though they need many more resources. You've seen throughout this presentation that there are a lot of gains that have been made. And so here we're showing the percentage of jurisdictions stratified by when they first received funding, who match viral hepatitis case reports with other health data sets. This is a very intensive data processing activity in order to better understand the characteristics of viral hepatitis cases. We see steady increases among newly funded jurisdictions. We see an increase and then a little bit of a decline among prior funded jurisdictions, but I will say that in 2022, 100% of the prior funded jurisdictions reported doing this activity. And so we did see just a little bit of a drop off in 2023. But certainly, we see that these newly funded jurisdictions are just really rapidly catching up here. Next slide, please. The other two indicators that we present in this way are having a viral hepatitis elimination plan. The newly funded jurisdictions, we see an increase. We see actually a doubling from 36% to 72% over just 2 years, very rapid increase. And then producing annual viral hepatitis surveillance summaries. And we see, with kind of over time, really sort of this is kind of flat in the prior funded jurisdictions, bumps up a little and comes back down, but a steady, really steady growth in these newly funded jurisdictions, just showing that the investment, is working. And so, this is just showing that, the federal government is getting bang for its buck. That's the story that we're trying to tell here. Okay, I'm going to pass to Isabel to talk about.
All right, I know it looks like I'm in a beautiful tropical place, but a storm rolled in, so if I drop off, it's because the storm got me. Anyway, so actually before I begin speaking on our recommendations, I really want to second what Dr. Bradley mentioned in terms of one of the key takeaways that considering the burden of viral hepatitis in the US in comparison to the resources provided to public health, it is astounding. It's impressive what this investment has accomplished in terms of surveillance system infrastructure. I also want to highlight that this work is being accomplished in conditions where there is extensive burnout among public health staff. There's volatility in terms of keeping these positions staffed. Health departments are implementing these surveillance activities in settings where the people with living and lived experience are justified in their hesitancy to be surveyed, and in situations where jurisdictions have to find the balance between protecting the communities we're intending to serve and also needing to demonstrate outcomes of these funding resources with the data being produced by the surveillance infrastructure. So that being said, monitoring these indicators against investments over time are critical to understanding where resources continue to be needed and to be expanded, especially considering, again, the amount that jurisdictions are tasked with, taking into consideration all these limitations. And then, like the big elephant in the room, the very uncertain times that we are living in. I would say then, in summary, our recommendations are to continue to build viral hepatitis surveillance capacity using a combination of federal and other funding sources, and to increase collaboration within the health department, specifically leveraging other infectious disease resources where possible to not only approach surveillance endemically, but to implement a holistic approach for people with living and lived experience. Next slide, please. So on the slide being presented, it is the cover letter included in this report that summarizes the report and also has been formatted for easy sharing. So going back to Dr. Bradley's praise for Signal, I think also you'll see throughout this report. Next slide, please. Again, next slide. Throughout this report, you'll see that the infographics, the snippets, the entire report has been very intentionally made to be user-friendly and shareable. I can say that at NASDAQ, we've already shared this report out with our respective partners. But again, now more than ever, it's essential for folks on this call to also share widely. We really want to make sure that this report makes the connection to the larger goal of elimination. So please share them, share the snippets. Also, in terms of what we're doing, we're going to promote this report in expert Q&A blogs. We're also going to ensure that we highlight best practices and really showcase how partners are using this report for advocacy purposes. And then we will continue to work with our national partner friends such as NBHR and CST. I think that's it. Yeah, turning it back over to Dr. Bradley.
Great. So just so you all know kind of what to expect in terms of dissemination for this report and future years. We're on the last day of July today, and we are officially launching this year's report today. I guess that puts us a day early because here we say that we're doing that in August. But we briefed our jurisdictional stakeholders last week. We always give them a first look because these are, as we've mentioned multiple times today, their data. And we're launching the report today publicly. It's now available for all of you. We hope, as Isabel said, that you will share the report, that you will use the infographics. There is also a Q&A with Melissa available on the website. There are many resources that go along with this report that we want you to download. You can use just as they are in your own presentations. This is the materials on HepVu are meant to be copied and pasted. So please feel free to use them. As with any good survey research, the minute you put a report out, you start the next survey. So we will actually be launching or fielding the next survey next month to the jurisdictions. Going forward, we're going to be fielding surveys in August and September and asking about the first 6 months of the year. We're doing that because we want to be releasing reports in a more timely way. And so what you can look for in future years is a report in the very early spring of each year reflecting findings from the previous year. So in March of 2026, you'll see the next report, which will reflect findings from 2025. We think this is an ideal time in terms of the ability of policymakers and advocacy partners to pay attention. And we don't want to get too far away from the time in the calendar year that the responses reflect. And so instead of reflecting the full year of surveillance practices, it will reflect the first 6 months. We've talked extensively with NASTAD and the jurisdictions about this, and everyone feels like the first 6 months is probably a pretty good indicator of what happens throughout the year, with a few changes, modifications to the questions. And so you should be expecting these reports to be coming out in a more timely way going forward, and we're really excited about the future of this report. So look for the next report in around March of next year with 4 data points. All right, everybody. Well, that brings us to the end, and we still have a few minutes for Q&A. I'm not seeing anything in the Q&A box yet. Any questions or comments, suggestions? I really appreciate you all being here today, and I know I speak for all of the panelists.
I will say when we were doing the briefing with the jurisdictions, I was pleasantly surprised that they added questions that they wanted to be asked, especially in terms of how the field is evolving. For example, RNA point of care testing for hepatitis C and annual reporting and how we're adjusting. And so I was very pleasantly surprised. You're like, all right, if you want it, you'll get it. Oh,
I
lots of
think the
praise for them.
jurisdictions they're very invested in this, and we're so happy
Yep,
because this really is for them.
absolutely. Oh yeah, there's so much praise coming through in the well, you're welcome. How do I get the email listserv? Oh, that's a good question. Oh,
Kathleen,
that's
could
one
you
good.
add a link to get it
Yeah.
for getting on the listserv for webinars? We would love to add you to our listserv.
Yes,
Everyone's
I will
welcome.
add a link. I will go ahead and send follow-up email with a recording of this presentation. It'll be online on HepVu, and I will include a link there so you guys can sign up.
And that will go out to all of the participants from today.
Yep.
Okay, super. Yeah, and then you all can, if there are folks who weren't able to attend today that might, benefit from seeing the presentation, please feel free to share the presentation with them. Thank you all for all the thank yous. This is a labor of love. So we love to see it.
Ooh, we got a good question from an anonymous attendee. What is something that gives you hope looking forward in hepatitis land? Ooh. Well, we are at a time, but I will say, among the folks that, especially where we work with in the hepatitis space, the health departments, they're still, regardless of what's happening in the volatility, I think they're really able to reconnect to their mission and their vision. And it's something that I need from them. So I really appreciate how we have this shared understanding, this shared vision, and knowing that we can all collectively, when we are feeling down or feeling hopeless, that we can turn to each other and really raise each other up. So there's that.
Yeah, I agree. I think I always say that the viral hepatitis field is small but mighty. It is a committed group of people, and I love being part of this field because the work is so important, and the people are so smart and so dedicated, and it's just a wonderful group to be part of. Also point of care testing. I do most of my work is in the health of people who inject drugs, and I think that that's going to be I hope that that's going to be a game changer for getting folks into treatment.
All right, I think this is more of a question for Doctors Bradley and Wardle, but do you look at other countries' progress towards hepatitis C elimination? Heard at a recent conference that Egypt and Belgium are ahead of the US in eliminating hep C. Thank you. Ooh, it's a good question for HepVu.
Yeah, we do. We typically during Global Hepatitis Awareness Month, we'll do a piece on global elimination, and we will usually do a Q&A with somebody in the global space. So look for that, and you can find the past Q&As that we've done on the HepVu website. So we do try to do a little bit of promotion around what other countries are doing in the elimination space. But you're right, there certainly are other countries that are ahead of where we are in the US, and that we could learn a lot from. Thank you for your question. Well, I think we're at time. Again, thank you all so much for being here with us. If this was your first HepVu webinar, please come back. I hope you enjoyed it, and please pass the surveillance status report far and wide. And thanks to our jurisdictional partners as always.